Well, good morning, everyone. I want to talk to you a little bit about what we're doing here. This is a series. This is the first big kickoff. It's a 10-part series. We'll be going through November. I'm hoping that everyone here and those of you listening around the country will be signing up for all of these because each one in the series builds off of the one before it. And in total, by the time you get to the end of this, you're going to have a wealth of knowledge that will help you help your clients. Today's live webinar and all future webinars are free. They're located on the NAHU Education Foundation's website, very similar to NAHU.org. It's just NAHUEF.org. And I encourage you to go back to your state and your local chapters and share this information because it's also going to be recorded. So there are many different ways to hear it today and pass it on after today. Now it's my pleasure to introduce the presenters for today's session. Suzanne F. Del Banco is the Executive Director of Catalyst for Payment Reform. Catalyst for Payment Reform is an independent, nonprofit corporation working on behalf of large healthcare purchasers to catalyze improvements on how to pay for healthcare services and to promote better and higher value in healthcare across the United States. In addition to her duties at CPR, Suzanne serves on the coordinating committee of the Measures Application Partnership for the U.S. Department of Health and Human Services, the Healthcare Incentives Improvement Institute Board, and she also participates in the Healthcare Executives Leadership Network. So she's very, very qualified to talk to us about this subject today. This is what she does. Many of you know Mark Gagne. Mark is the co-owner and chief innovation officer of Borislow Insurance, located in the greater Boston area. Borislow is an employee benefits brokerage and consulting firm like many of you serve in. They serve over 350 corporate and 2,000 individual clients and more than 100,000 members in 35 states across the country. Mark has more than 25 years of experience in the industry and is a pioneer in the use of consumer-driven wellness and health plans, and is also very, very experienced in this issue that we are talking about today, which is why he's on our panel. So without any further delay, I'd like to get started and have you welcome our two panelists.
Thank you, Janet. Suzanne, good morning.
Good morning.
Welcome to NAHU.
Thank you.
Big welcome for Suzanne Del Banco. Suzanne, you're a bit of a rock star in our business because you're intimately familiar with many of the issues that we'll be talking about over the next 10 webinar series. This morning, what we're going to talk about is the high cost of healthcare, what's driving it, and most importantly, what can we as brokers, producers, agents, and advisors do to help our clients deal with this very daunting challenge. We thought we'd start out this morning's discussion with a quote from Albert Einstein. Albert Einstein once said, "The world as we have created it is a process of our thinking. It cannot be changed without changing our thinking." So how do we all survive and thrive in a post-ACA environment? I think many of you know I hail from the Commonwealth of Massachusetts. We had a law very similar to that put in place in 2006. And as you can see from Janet's introduction of our organization, not only have we survived, we've thrived. And everyone in this audience, all of our members all across the country, can do the exact same thing. 2014 was a transformational year in our business as the ACA took firm hold. The rate of change in our world is accelerating rapidly, and complexity is growing exponentially. Our clients pay us to make things that are complex, simple, and where there's haze and a lack of clarity, to create clear vision for them. You see, when they're frozen, they get stuck, and our job is to unstuck them. Your clients pay you, our clients pay us, to manage their risk and create innovative solutions to very complicated issues, frankly, issues that have nothing to do with their business, but something that every one of them invest in to attract and retain the human talent they use to run their businesses. Competition is fierce and growing more savvy every day. Technology is revolutionizing the world. Think about Skype and what it did to long-distance calling. Think about Amazon and what it did to Barnes & Noble. Think about Uber, who I know many of us have used since we've been here, especially in the snowstorms. not only getting us there quicker, but also at less cost. Those are just three very quick examples of how technology is transforming our world. So to survive and thrive, you must evolve from broker, producer, agent to strategic advisor. And strategic advisors is not a fancy word. What it means is you're thinking big picture, you're creating vision, you're understanding your clients' needs and objectives and their very unique challenges, and trying to help them create a path to certainty and to a nice future. I'll lay it out this way and be very succinct with it. Either we disrupt what we're doing, or we will be disrupted. Just think about that for a minute. We disrupt what we're doing, or we will be disrupted, like the three examples that I gave you. In January and February, Chuck Alston, who is working with us on this project, and Robert Woods Johnson Foundation, did a survey with all of you, and 525 brokers responded to that survey and asked, an important role for me as a broker is to educate my clients about insurance products and alternative payment methods to improve quality and lower cost. You can see the numbers are overwhelming, that this subject matter is something that all of you care very deeply about. Understanding how clients can leverage payment strategies to help control costs and improve quality. Again, the survey results show an amazing, overwhelming majority of you really believe that you have to invest in learning these types of things to relay those out to your clients so that you can develop solutions for them. And so with that, we know the healthcare landscape is changing, and Suzanne's going to walk you through a little bit and carry on from where I just left off and kind of set the stage for you about the conversation we're going to have this morning.
So seeing those survey results reminded me of another survey that we participated on with Aon Hewitt, where we surveyed employers to find out what they understood in terms of payment reform. Did they understand what it was? Did they understand what to do about it? And overwhelmingly, they are very confused. So there is a significant role for all of you as you become experts in this topic to pass on that expertise. But it is a very confusing time for the employers, certainly that I work with, for smaller employers, and for all of you, because so much is changing so quickly. And I used to joke about healthcare. It made me feel like I had special future vision powers. I could look in a crystal ball and know what was going to happen because things change so slowly. But that's not true over the last few years. I think things are changing so rapidly now that when I've done a strategic plan for my organization, I can't even think about what we're going to be doing 2 years from now because it's really hard to know what the big issues are going to be. But before we get into healthcare costs and payment reform, I just wanted to put it in the context of a tremendous number of changes that are happening in the healthcare landscape. I think, whether you like the Affordable Care Act or not, it has created amazing momentum in multiple directions. And so if you look at this picture here, you see the windsurfer down in the bottom left corner. I think the wind and the sails of so many changes that were kind of, marching along very slowly is really unprecedented. So as we are looking at the issues of healthcare costs, we're looking at the issues of payment reform, we have to recognize that the provider landscape is changing dramatically. Doctors and hospitals are merging and coming together like never before. And while this is good in the name of care coordination and better collaboration to help people get healthy, it's also creating an incredible amount of market power and the ability to raise prices. We are seeing rapid changes in how healthcare is delivered as providers integrate and try to figure out how to take care of the whole patient across a continuum of time. We're seeing all kinds of delivery reforms that are occurring, and there need to be new payment models that support those. We're seeing employers shake up the market when they feel like they're not getting a good deal. They're willing to look beyond their health insurers. They're willing to look beyond their geographies. They're flying people across the country to get procedures done, sometimes even out of the country because it's cheaper. We're seeing new markets for insurance, of course. You guys know much more about that than I do. And we're also seeing an unprecedented number of experimentation with incentives for consumers to get them more in the game, thinking about their healthcare choices, making smarter choices, spending their money more wisely. And then we're also engaging consumers with information that they've never had before. Over the last 15 years, the amount of information available on the quality and safety of healthcare providers has been growing. Patients can now even look at their doctor's notes about their visit and see what their doctors wrote about them. I mean, we are in an unprecedented era of transparency for consumers. And I know you talked some about transparency yesterday. And all of this is joined by the fact that, to quote one health plan executive, we are experiencing a payment reform arms race right now. So when Catalyst for Payment Reform got started in 2010, something like 1 to 3% of every dollar going to doctors and hospitals was tied to performance. Now we have skyrocketed beyond that, and I'll share some information about that with you in a moment. So there's just a huge amount of experimentation and change at foot right now. So why do we need to make so many changes? I know this is speaking to the well-informed, but healthcare costs are a big problem in this country. And while they have slowed over the last 5 years, the expectation is that they're going to pick up again, and that by 2020, total healthcare spending is projected to be $4.6 billion. And, you know, some people say that's okay.
Trillion.
Oh, sorry, trillion. Sorry, thank you. I need to wake up. I'm on California time.
6:30 in her body right now.
But some people say that's okay. You know, maybe that's an expression of our values as a country, that we value health and health care above everything else, and that's what we want to spend our money on. But I think we could come up with a lot of arguments about how we could spend our money better in this country. And so when you think about the you know, who's footing the bill, there's many of us are footing the bill in different ways, but employers do foot a lot of the bill. And on average, employers are subsidizing about 58% of employers' healthcare costs right now. And by the numbers, a typical family of four has about $23,000 in medical costs each year, and that's split between the employer and the employee, with the employer paying about $13,000 of it and the employee paying the remaining almost $10,000. And so when you think about that, you know, it's a significant portion of household income. And as I've said in many healthcare conference settings before, many of us are paid way too much to understand what that really means for the typical family in this country. And it is eating up a huge portion of their disposable income.
So not only is it expensive, Suzanne, we're also seeing that the average family spends 15 minutes making that decision that you just talked about.
Yeah.
So can you imagine going out and buying an automobile, spending
No.
$25,000 and spending 15 minutes making that buying decision? I don't think many of us could really, you know, say we'd operate that way.
And I would assume that in part people make those decisions quickly because they don't understand, they throw their hands up in the air and they're not really sure how to proceed, so they just move ahead.
Yep.
Whereas, you know, we've got consumer reports for dishwashers and cars.
Right.
You know, we're working that way, you know, working toward that in healthcare, but we're still not quite there. So then the question is, you know, what's driving healthcare costs? Now, you know, if I go to a cocktail party with my friends, you know, who are sort of cross-section of life and they don't focus on healthcare, and I ask them, what's driving healthcare costs? They'll probably say, you know, maybe new technologies, the aging population, but it's actually incredibly complicated. There is no single driver of healthcare cost growth right now, and there's also no single solution. So this is why I will be employed for a very long time, you know, and all of you will too.
As will all of us.
Yeah, exactly.
Right.
Because there are so many different drivers and so many different ways we have to address each of those. Did you want to comment on anything before I get to the details?
I'd also like to talk about, and we talked a little bit about this yesterday in the transparency panel, healthcare trend is made up of three components: unit cost, utilization, and provider mix. Unit cost is 50% of trend on average. Utilization is about 35%, and provider mix is about 15%. Unit cost is the big driver, though, of rising healthcare trend.
Right. And so going back to when I talked about the changes happening in the healthcare landscape, and I talked about consolidation among hospitals and hospitals with physicians and physician groups, that is probably the single biggest driver of healthcare cost growth right now. It's price. It's something that's bargained. It's something that's negotiated. So that gives us optimism because maybe there are ways to address it. It's not as intractable as an aging population, for example, but it is very complicated. And so when we think about what the top drivers of healthcare costs are, I think all of you could probably come up with most of the items on this list. We've got fee-for-service, which I'll talk about in a moment, the way we pay for care, which is inherently problematic, and that's, again, why we're going to talk about payment reform throughout the series. We have fragmentation in the way that healthcare is delivered, so there's a lot of duplication. There's overuse of expensive care that's not necessary, and there's also underuse of care that should be happening that could ultimately lead to more economic spending in healthcare. There's a huge administrative burden. The cacophony of contracts and deals and relationships across all the players leads to a lot of administrative overhead. We do have an aging population and an increasingly burdened population when it comes to chronic disease. There are advances in medical technology, including drugs, that do drive prices up and costs up. The tax treatment of health insurance, that's something that I'm sure you could all comment on. Insurance benefit design, whether or not the consumer actually has any stake in the game in terms of how much spending there is, can impact the utilization of care and the cost of care. The lack, even though we've made a lot of progress, there's still a lack of transparency around quality and price that prohibits us from really having a market that works as smoothly as it could and as efficiently as it could. There are also some cultural biases that influence how people use healthcare. And again, I won't go on and on about it, but the changing provider landscape is having a big impact. Did you want to add anything to that?
Yeah, I would just say that the lack of transparency we talked about a lot about yesterday. And the reality is if you can't see it, you can't measure it. If you can't measure it, you can't improve it. And we all know that that's the source of a lot of frustration. How do you reform what you can't see?
Right, right. And how do you make good choices if you don't have information about them?
Correct.
So what are the leading areas of spending for employers right now? I mean, you could look at lots of different studies and come up with a slightly different list here, but this one particular one from Chuban Health shows that there's a lot of spending on musculoskeletal care, cancer care, cardiovascular, gastrointestinal, and of course for an employed population, maternity. And maternity is an area I'll talk about again a little bit more in a moment. In all of these areas, we know that care isn't always following the guidelines. We know that there's too much care provided in some cases, and we know that there's too little in others. So not only are we spending too much, but we're also not necessarily getting the best value for our dollars. So what do we get for all this spending? You know, we spend more in this country per person than any other country. And again, like I said, it could be an expression of our values of how much we care about healthcare, but then we probably should do a better job at getting outcomes for that spending than we do. Because when you look at our outcomes compared to other countries, we rank very low when it comes to quality and when it comes to safety. We do well on certain things. I think you know when you compare ourselves to other countries where there's a national health system and there's sort of long queues for specialists, we can get in to see a specialist like that. And so, you know, some of us think that that's a good thing. Also, we do a little bit better on preventive care and on having care be patient-centered. But for all the spending to have such poor outcomes compared to other countries that spend far less, it's not really anything to be proud of, and we've got to keep working on that.
This data point always surprises me when it shows that we're last in quality, because the reality is a lot of foreign dignitaries come from many places all over the world. Marriott's made a big business out of this, where people fly in from other countries to get care in our country. So I always wonder, is it an issue of quality or is it an issue of reporting on the quality that we have?
I think I will get into this in a moment. Actually, it's a reflection of the fact that quality varies tremendously.
So
you can get
variation.
some of the best care in the world in this country, but you can also get some of the worst. And I think all of us as human beings like to believe that our doctor's great. You know, I've chosen a doctor, I want to bolster that decision, and I'm going to tell myself my doctor's better than the average. So when I go into the office, I am going to get evidence-based care. I am going to get the right care. I am going to have the right decisions made for me, or made with me, ideally. But in many cases, that's just not true. And when you look at the data, there are some really interesting examples of where this is not true. So using the example of maternity care, which is one type of care where people plan long in advance for where they're going to have their baby, for example. So it's a really great opportunity to help people shop, make good decisions, think ahead about the kind of care they want. But we see that there's huge divergence from what the evidence suggests should be happening. In this country, we have, out of all births, 34% of babies are arriving through cesarean delivery right now. The World Health Organization suggests that it should be somewhere between 5 and 10%. And in fact, anything over 15% is likely to cause harm. So you can see how far we are from where we actually should be. And in California, the California Healthcare Foundation did a study showing that depending on which hospital a woman goes to deliver her baby, her experience in labor and delivery and the outcomes are going to be markedly different. Because some hospitals have done a great job, for example, of doing away with early elective deliveries before a baby is fully baked and ready to come out. Other hospitals, you know, it's a standard practice. And so you see those babies ending up in the NICU, and you see consequences. And so it's just a good example of how, you know, from one institution to the next, there really is a lot of variation. And if you look at data for the country, the rate of hospitalizations that could have been avoided, varies tremendously. So that shows you that it's about how the care is being delivered that leads to these things. And it's not just because populations have different characteristics or something in these different areas. It has to do with how care is delivered.
It reminds me of the old adage. Do you know what they call the physician who graduated in the bottom 10% of his class?
Above average?
Doctor.
A doctor, yeah. Yeah. We can't all be above average, but
That's
people
correct.
really, really want to believe that they are. And earlier in my career, I was focused a lot on measuring quality and publicly reporting quality. And I cannot tell you how many states I visited where they said, but we're different. You shouldn't compare us to the national benchmark because we're different. But in fact, that becomes an excuse for being, whatever you are, where you are, and not rising to the level that you could be. Because when you start comparing across states and you see that in a state the best hospital is far worse than the worst hospital in another state, it's just, you got to look across the board and figure out, where the standard of practice can and should be. So we know that quality varies tremendously. So even though we don't have perfect quality information today, we do have a lot more than we used to have, and we're working on getting better quality data. But the other area that we've really only just become educated about over the last 5 years is how much payment amounts vary. Now, I think health insurers have known this for a long time, but really it's just been an awakening even for the large employers that I work with to realize that they are paying wildly different amounts for the same care, regardless of the quality of that care. And in fact, there's no correlation between the level of quality and the price. Right now, there's just nothing in the market that's forcing that to happen. And in fact, price is probably much more often a reflection of the bargaining power or the negotiating skills of a provider or a health insurer than it is anything else. And so when you start thinking about how much quality and safety vary, how much the amount we pay varies, you know that a lot of the time we're getting a bad deal. And that is something that we can do something about, and that's really where payment reform comes in. Just one last example. This is just looking at maternity care and the range in what we pay. This table is hard to read, but just for a regular cesarean delivery, the price range can be from $3,200 to $16,000, a five-fold difference. For vaginal delivery, from $1,800 to $11,000, a six-fold difference. So it just shows you, again, as another example, that prices are all over the map. And in fact, where I live in the Bay Area, Safeway did a study looking at what they were paying for preventive screening colonoscopies, and they were paying anywhere from $600 to $6,000 for the same procedure, same anesthesia, and it starts looking a little crazy when you dig into the numbers.
And in my home state of Massachusetts, we've had our Attorney General do 3 reports,
Right.
and all 3 studies showed the average variation in price is 600% for the exact same service.
So, so then the question becomes, does how we pay for care make a difference? Is any of this a reflection of what we're doing today in terms of how we pay for care, and will changing how we pay for care get us to a better place in terms of the quality and the affordability of health care? And obviously, since I run an organization called Catalyst for Payment Reform, I firmly believe that the answer is yes. But the truth is that right now we're still mostly using a fee-for-service model, which, as all of you know, means that we pay for each visit, service, procedure, test independently, and that leads to a motivation on the part of providers to do more and to provide more expensive care, because that's how they generate revenue. And this also means that we pay for care regardless of its quality or the outcomes that the patients ultimately experience. And so without tying payment in some way to how providers perform on behalf of their patients, or without making sure that payments are designed to support better quality, we're really missing an opportunity. And so while today we're paying for many tests and procedures regardless of necessity, we are also not paying for things that should be happening. So when people talk about fee-for-service being a problem, they usually only focus on what it does do, not on what it doesn't do. But it also does not compensate providers for things like managing the care of their patients and coordinating it, and all the stuff that creates a seamless and positive experience for the patient. So there's a lot of things wrong with how we pay for care. But the truth is, we talk about payment reform in a moment, almost every type of payment reform we're trying in this country right now is still built on a fee-for-service chassis. So those of us who think about this every day recognize that while we want to move to different forms of payment, we're also going to be living with fee-for-service for quite a while. And we should take some time to think about how we can improve it at the same time as we think about new models.
And I would just tack on to that at the end of the day, is it really about how we pay, or is it about can we see what's being paid and how it's being paid? So I think we're going to explore that as we move a little bit further on in our presentation.
Yep. And the other thing I'll add to it, which I'm not going to probably touch on anywhere else, is that it's also the amount that we pay.
Right.
So in some cases, we pay too little for things that should be happening more, and we pay too much for things that are happening too often. And you could even just stick with fee-for-service and change the relative amounts we pay for things and probably get better care. So that's, again, an example of where we can work on improving fee-for-service at the same time as we look at new methods of payment. So, why do we need payment reform? Well, I think I've already made a pretty good case about the fact that we're getting very uneven value. And by value, I mean really the combination of quality of care and the cost of care. To pay, if we want to pay for the care that we actually want, and including, care coordination, as I've talked about, and if we don't want to pay for the care that we don't want, that's wasteful, that's harmful, we probably need to think about how we're, the methods that we're using to pay for care. But we also want payment reform because we want to align the incentives properly across the board. We want it to be beneficial to providers to do right by their patients. We want it to be beneficial to patients to make smart decisions. And so we're going to talk a little bit at the end here about how important benefit design is also in this whole equation. So we're focused right now on payment reform, how we pay doctors and hospitals, but at the end of the day, we also want consumers, individual patients, to be attracted to those hospitals and doctors that are doing well. So that's an important part of it too.
It's a basic issue of supply and demand, balancing both supply in terms of how physicians and our providers are paid, but also how the consumers engage in making educated decisions.
Right. So what is payment reform? I think you could probably find a lot of different definitions, but I'll share with you what Catalyst for Payment Reform uses as its working definition. So payment reform is payment that reflects provider performance, especially the quality and safety of care that providers deliver. It also is payment methods that are designed to spur efficiency and reduce unnecessary spending. You will find that some payment methods do the first, some payment methods do the second, and ideally we would have payment methods that address both of these challenges. And in our view, if a payment method only addresses efficiency and it doesn't have a component that focuses on the quality of care, then to us it's not payment reform. It really has to have a quality component. And when I say quality component, I mean when we're paying that doctor or hospital, there's something in that overall payment amount that doctor or hospital could get that is tied to the quality of care that she or he is providing. Or that payment method is designed specifically to improve quality. So to us, at the end of the day, if you're just cutting costs, then let's go back to just negotiating for volume discounts. That's what employers have been doing for years, and we know what we've been getting with that.
Right.
Anything else you want to add?
No.
So payment reform is really a complicated topic. Just how we pay for care in this country is complicated. So we decided when we started at CPR that we needed to create a framework to help us all speak the same language. So we created this graphic. You can critique it later. I'd love your feedback. But basically what it shows is as you move from left to right, things get much more complicated, but potentially have greater benefit in terms of getting better value for healthcare spending. So on the left side, you've got old-fashioned fee-for-service, what we're dealing with now. As you move to the center, you've got package pricing, if you will, for an episode of care where you've got a payment that you make to providers, they figure out how to divide it among them, and they take care of a patient for a hip replacement or a labor and delivery or some other chronic condition episode over the course of a year. As you move from left to right, it gets more complicated. You get more resistance on the part of healthcare providers, less readiness on the part of healthcare providers, but also potential greater accountability on the part of providers for the care they're delivering, and a forcing function that makes providers have to coordinate and collaborate with each other, which could obviously benefit the patient. All of these methods can be improved based on what we've tried so far in our experimentations with them. Like I said, for us at CPR, if a payment method doesn't have some kind of quality component, it's not good enough. And we have a lot of fee-for-service in the market that has no quality component. We even have capitation in the market that has no quality component. There isn't so much bundled payment anymore without a quality component, but there was. So we need to think about all of these as tools in our toolbox, and how to sharpen them and make them work better.
And Suzanne, we've talked about this. You think that we're not going to abandon the world of fee for service. We'll have to, evolve through that into these different forms of payment, right? I guess the other part of this is we're talking about quality, which is outcomes based relative to the care that's being delivered. Is there an experience component at the consumer level that's part of quality in your mind?
Yeah, absolutely. I mean, I think our definition of quality has been changing over time. At the end of the day, I think when any of us become sick, really what we want is to become better, and that's the most important thing. Mm-hmm. But there are other dimensions of quality to measure. What is the patient's experience with their care? Only I, the patient, can inform those who want to know about the quality of my provider whether my pain was managed all right, or whether I understood my discharge instructions enough to get better once I got home. So there are elements of quality that really can only come from the mouth of the patient. And that's an incredibly important component of measuring quality, as is, did you die or not, or did you have a complication? So there's many different dimensions.
It'd be hard to have that conversation if you died, right?
There are many different dimensions of quality measurement, and we're getting more sophisticated over time. I think there's a lot of excitement now around something called patient-reported outcomes, which have to do with functionality. So, for example, if I have a hip replacement, how many days till I return to work? How many days till I could walk without pain? That sort of thing, which is very meaningful to a patient who's trying to choose a provider. I'm going to want to go to someone who gets me back up on my feet and feeling comfortable quickly as compared to someone who's not.
I would add another layer to that. If you've ever been on the end of the line, and I have, I'm a skin cancer survivor, and when you get that call that says you have malignant whatever it is, it's very lonely. You can't think. You start to sweat. You start to envision all these terrible things that you see with your family and people that you know. So I think physicians also need to be aware of that and let you know, look, not only am I going to render great care for you, but I'm also going to hold your hand through that process.
Yeah, that doesn't always happen.
No, it doesn't.
So that payment reform framework, I hope it was slightly helpful. What I want to do now is also give you a different slice, which is to think about all the payment reforms that are happening right now, and I know this table is hard to read, are really divided into three categories. When you think about it from the healthcare provider's experience, is this change in payment method going to help potentially increase my income? Is there a potential upside for me if I do well? Is this payment method potentially going to decrease my income? If I don't do well, am I going to be paid less? And then the two-sided model, which is that if I do well, I might earn more, and if I do poorly, I might earn less. So at the end of the day, there's many different types of experimentation happening, but they all really fall into these three buckets. So when you think about it, when you're working with healthcare providers, they can be tough to change. And so most experiments you find will start with upside only, offering the carrot, saying if you do well, you will get a bonus. So, for example, pay for performance, many of you have heard of, where if a provider performs well on certain quality measures, they can earn, they get a bonus check every quarter or once a year. And there are other methods where it's upside only, like all of a sudden you're getting paid for care coordination, or you're getting paid for spending time doing shared decision making with your patient, or there is a budget set, and you are told that if you spend less than what the budget is, and you hit all your quality targets, you get to share in the savings over what was spent on the same population last year. So there's many different types of upside-only payment reforms that are occurring in the marketplace. They are by far the most prevalent. They're the easiest to start with. We also, though, have some examples of downside-only reforms that have been in the market for several years now. For example, when hospitals leave a patient with a hospital or healthcare-acquired infection due to the course of their care in the hospital, they will not get extra payment for taking care of that portion of the patient's care anymore. Another example, in South Carolina, the Medicaid agency and the Blues plan there that together cover 85% of births stop paying for early elective deliveries. And so if a provider delivers a baby before 39 weeks for no medical reason, they will not get paid for it. So they can do it, but they're going to lose money as a result. So those are some examples of downside. And then two-sided risk, this is where many of us believe that we have to get to. We need to create the strongest incentives possible, but there has to be some carrot and some stick to the approach, most likely, to get the greatest behavior change. And so when we hear, I think there are probably more conferences in healthcare on bundled payment than any other topic. But right now, we're only at about 1% of payment going to doctors and hospitals that's in the form of bundled payment. And that means like a package price. You get a package price for vacation, your cruise and your flight and your car, everything's included. In this situation, that's the same idea. Everything from start to finish with an episode of care is included in that payment. There are very few providers that know how to handle that yet. And the other little secret is there are very few health insurers who know how to make those payments. Most of them who are doing it now are literally reconciling claims in a back room and turning that into a bundled payment. It's not automated at all.
Is it a technology issue, really, you think? Or
it is partly a technology issue because it will cost each health plan millions of dollars
to invest in that
to invest in the infrastructure to do it,
and
they've just been kind of hedging their bets so far and haven't invested in it. But then also shared risk, the idea, again, if you have a budget set and you overspend, as a provider, you have to eat those costs. So really all the payment reforms that are in the market fall into these buckets. Did you want to add anything?
No, perfect.
So let me just give you a few examples of what's working right now. And I will say that these are all very anecdotal. You'll notice that. Because we do not have a preponderance of evidence about which new methods of payment are going to pan out for us. We also know that they're very contextually based. So there is no one-size-fits-all solution to payment reform. What works in one market might not work in another market. What works with one provider group might not work with another provider group. So it's just frustratingly complex, but that's just the way it is. So in some early experiments with patient-centered medical homes at Geisinger, for example, very famous health system in central Pennsylvania, there is they found a 7% net savings when there was a primary care doctor playing a very central role in coordinating a patient's care. Most of the savings were accomplished through reducing hospital admissions. The Department of Defense at Hill Air Force Base in Utah similarly found that having patient-centered medical homes helped patients control their blood sugar much better, saving them about $300,000 a year.
Mr. Thorne, I'm sure you're happy to hear that, right?
Absolutely. Shared savings. There has been some exciting experimentation on the part of some of the employers I work with, like the Boeing company, where for very complicated patients, they essentially created what they called the intensive outpatient care program, which was it was like an outpatient ICU, if you will, for patients that really needed serious intervention. These were patients ending up in the ER a lot, and sometimes the root causes of their problems had to do with not having adequate housing or not having adequate food or things like that. And so by hiring a case manager who could really help the patient figure out what was the root of the problem and why they were such a high utilizer of healthcare, they were able to save a huge amount of money, 20%. The best part about it, of course, was that the patients got better. And shared savings is the predominant model of payment now for accountable care organizations, if you've heard about those, spurred by the Affordable Care Act, where doctors and hospitals are supposed to come together and care for the health of a population. Non-payment, I already shared this example in maternity. I will share with you that in the first quarter of South Carolina adopting the non-payment policy for early elective deliveries, they saved $6 million in one quarter. And they're expecting that over the course of a 6-year period to save at least $11 million for the state by not paying any more for early elective deliveries. So the last comment I want to make is going back to something I said earlier, which is that all these payment reforms, while promising, and we're in an age of bold experimentation, we also need to get to rigorous evaluation to figure out what works in what context so we can spread the models that really work. I would be lying to you if I told you we knew exactly how to do it. We are so far from that. But we know that we have to try. We know we have to experiment and learn from that. The other thing we know we have to do is line up payment reform with benefit design. Right. Mark was already commenting on that. And there are so many exciting things happening in the area of benefit design, some of which we'll be sharing with you throughout the webinar series. Price and quality transparency are a key part to help the patient be part of the smart decision making when it comes to selecting healthcare. Reference pricing, where employers set a maximum price for a service and patients know they're going to have to pay the difference if they go somewhere more expensive. Centers of excellence, focused areas where a given hospital becomes expert at a certain procedure or service, and the patient gets an incentive to choose that center because outcomes are likely to be better and overall total costs are likely to be lower because care is delivered right the first time. And new types of networks for providers where patients have incentives to choose providers that have already met certain quality and cost criteria. And case management, like the Boeing example I gave you for high-cost beneficiaries. There's so many exciting ways in which we can engage consumers more than we have in the past. And by lining that up with payment reform, then you really might get the incentives lined up, the stars lined up even, to lead to better value in healthcare spending.
And the good news here is you're talking to an audience full of benefit design experts.
Yep, exactly. So that's how part of what you've been focusing on pairs with the incentives that we need to create also for those who are delivering the care. So I'm going to turn it over to Mark and just say that I'm really looking forward to getting to know many of you and working with NAHU through this whole project to educate all of you as best we can about what we know about payment reform, but I equally will learn a lot from you guys.
Sounds great. So as we opened in the beginning of our discussion, 2014 was a transformational year in our business. I was saying to somebody yesterday that 1-hour conversations now take 6 hours. And trying to manufacture more hours in your day, I haven't figured that out yet. Frankly, I probably wouldn't be doing this if I could. The rate of change is accelerating and complexity is growing exponentially. Our clients pay us to make things clear when they're hazy, and they pay us to manage their risk effectively. And at the end of the day, we know competition is fierce. Technology is changing the way we do our business. I think healthcare is probably the last bastion of technology in terms of technology impacting in industry, and its time has definitely come. To survive and thrive, all of us as brokers, producers, agents need to really evolve to being strategic advisors and to really understand the content. If we understand the content, we're able to have an informed conversation with our clients and really be strategic. Rather than selling a product, rather than selling a service, we're actually helping them think through what is the strategy. There's very big differences between product, services, and strategy, and all of us have to make that adoption so that we can evolve. As he said in the beginning of our discussion, we either disrupt what we're doing and how we've been doing it, or we will be disrupted.
Before you move on, I just wanted to let the audience know, I think you all know, if you have questions, I think they're passing out cards, you can write them on, and we'll be happy to answer them in a moment.
That's correct. So you should have seen, I think we've seen some people moving around with some index cards, which is great. What I wanted to do is, before we started answering questions, I'm going to tee up what our next webinar series is. Our next webinar series is going to be focused on price transparency, an issue near and dear to all of our hearts. This statistic, I think, is understated, and Suzanne and I actually had a conversation about that. With an almost $3 trillion, projected to be $4.6 trillion, with a T, in 2020. At the end of the day, they're suggesting that we could actually save or avoid $36 billion of cost through transparency. And through the work that Ryan Thorne has allowed us to continue on transparency, we'll continue to bring that value to you, and I look forward to doing that with Suzanne. So with that being said, I'd like to take some questions from the audience.
Okay, good morning, Suzanne and Mark. We'll try to get through as many of these as we can. First question, could you comment on how these cost and quality-based payment methods will differ from capitation-based models from yesteryear?
Sure. So, the cynic in me says that we just changed the name from capitation to global payment, so people didn't realize we were trying to do the same thing all over again.
I've made the same argument in my home state.
Because, people kind of get the, their hackles up when they hear capitation. They're worried about it because they remember the backlash by consumers feeling like care was withheld and they couldn't get to the doctors they wanted to because there was, the primary care doctor standing there as the gatekeeper. I think we've gotten smarter about how to do capitation in that quality needs to be a component of it. And I talked about how we don't take any method to be a payment reform method if it doesn't have a quality component. So I think in many ways this new phrase global payment is really just capitation with some checks and balances around quality. So whether or not global payment ultimately will work is a question. It is amazing how every set of incentives creates a set of behaviors, and you try to line up those incentives just right to get it right, but one of the concerns about capitation was there wasn't enough productivity on the part of providers because, if you keep the patients away, you might get to keep some of that capitated payment you got. So how, with global payment, will we not only pay attention to quality, but also make sure there's the right level of productivity? There's a lot of challenges with it. Some people think that that's where we should put all of our eggs in that basket, and I think we're going to have to experiment more to learn whether that's true.
Bob?
Next question. Transparency is great, but will it address the issue of provider consolidation and hospital consolidation and the price impact that is having on medical care costs?
I'll give that to you.
Yeah, so I think that that transparency and provider consolidation have a very interesting relationship. Without transparency, it can become very obscure to us what the impact of provider consolidation is. And most of our members were completely unaware of how much consolidation in their markets was driving up costs. Now, they all had an anecdote. Oh my gosh, when this hospital bought that hospital, the prices skyrocketed. So they had anecdote, but they didn't realize that the sum of anecdote was actually an impact on their healthcare costs. So without transparency, I think consolidation and its ill effects can happen without really much to stop it. With transparency, with greater awareness of how much prices vary, I think people can get smarter about whether or not it's worth going to the high-cost center. And one of my idols, who's in your state, Dolores Mitchell, who buys healthcare for the state employees, has said to some of the very well-known dominant providers in the market, "You charge 40% more? Prove to me you're 40% better." And the conversation ends. They can't do it. And so I think that transparency is so incredibly important. The other thing I would say, though, is in markets where there are very dominant providers, they can put the kibosh on transparency. They insist in their contracts with health plans that they shall not reveal their prices, do not tell consumers how much we cost compared to somebody else, and that can be a big problem too.
I would tack on to that, Suzanne. That's a mechanical issue. Contracts can be amended to stop that. I would also say provider consolidation is a concern for me. Without competition, cost goes up, quality doesn't go anywhere, it might even go down.
Right.
If we look at LASIK eye surgery as an example, LASIK eye surgery is not covered by insurance. Over the last 10 years, the cost of LASIK eye surgery has gone up 18%. Healthcare costs in that same period of time have gone up 119%.
Right.
Next question. We've talked about cutting costs by having more accountability from providers and more transparency. But what about the prescription drug cost and the transparency there?
Great question.
Yeah, so we have just been trying to educate ourselves at Catalyst for Payment Reform about pharmacy in general and also specialty pharmacy. And this is where payment reform really comes in, because imagine as a healthcare provider, if you were being held accountable for all of the costs of your patient's care, including pharmacy. Let's say you're getting paid through a bundled payment for cancer care, and the drugs that your patients are using as part of the cost that have to be covered by that bundled payment. You would get a lot more disciplined about looking at the cost effectiveness of the different therapies and finding something that would be beneficial to your patient, but also not unnecessarily expensive. So I think that payment reform and pharmacy costs are very much related, even though right now there's a lot of pharmacy costs are over here, we're focused on the medical care. I think it's going to come together.
Yeah, in fact, we're seeing accelerated trend in pharmacy right now. And in my home state, 18 to 22%, and 18 to 22% because of designer drugs.
Yep.
The wonderful thing is pharmaceutical companies are developing drugs that actually are saving lives. If we look at Sovaldi as an example with hepatitis C, what most people don't know is that drug really is not effective until you're at the latter stages of hep C, and so it can be inappropriately prescribed earlier on, and at the end of the day, it's not effective. Wonderful part is it can be a cure. The hard part is it's $80,000 per treatment.
Right.
And without people really understanding when to apply that, you might spend more inefficiently than you really should.
Okay. Next question. How do you anticipate the new ICD-10 coding due out in October of 2015 affecting bundled payments to doctors and hospitals?
I don't really have a good answer to that except to say that everybody seems to be behind on getting ready for that, and I can only imagine it will just slow things down, and that, as slow adoption as we've seen of bundled payment, this will just add to the complications.
I mean, I was just having a conversation with a member yesterday, and they were talking to me about these ICD-10 codes, and they talked about some of the codes that have actually been developed. There's a code. Did you know this? There's a code if you've been struck by lightning twice. There's a code if you've been kicked by a horse. I mean, really? We have to develop codes to explain those types of things? So I'm not sold on this helping us do anything with relating to cost.
Actually, Mark, in lieu of your comment, the next question is, how do we reform what we can't see? If the actual cost of health care is virtually unknown, how do we measure it and improve it?
Suzanne, I'm going to throw that one over to you.
So this is such an interesting conversation because the thing that has always struck me as amazing is that if you go to a hospital, let's not even say CEO, but CFO, and you ask that CFO, how much does it cost, how much does it truly cost you to do a hip replacement? We'll just use something discreet and easy. They don't actually know because they think about what the total cost of delivering care is over the course of the year to for the typical patients that come in and what they need, and they know what kind of margin they want to get. And so when they negotiate for their rates with health insurers and other payers, they make sure that they get that margin, but they don't actually know what a particular service costs them. They do all kinds of cross subsidies, to make sure that if they are losing money over here, they're making money over here to make sure that they can make ends meet. And so the bottom line is that even those delivering care don't have a line of sight into exactly what things cost them. And I think transparency on price and payment amounts is going to help us, policymakers, insurers, purchasers, all of you, understand more about the relationship between quality and price and all those sorts of things. But that's very different from the question of actually understanding healthcare costs, which I think very few people do.
Mm-hmm. And staying virtually on the same topic, the Affordable Care Act focuses its attention on insurance rules and regulations and leaves the actual cost of health care out of its design. Do you believe that payment reform will address rising costs, and if so, what's the first step?
Yeah, I think one of the recurring nightmares that some of us have is that we'll wake up 5 years from now and 100% of payments will be flowing through new methods, but our quality won't be any better and healthcare won't have gotten any more affordable. So I think payment reform in and of itself is not a cure for healthcare costs, but if done right and the details really matter, it could really address some of the perverse incentives in the marketplace that are leading to higher costs. It's really to be determined.
So Suzanne, I'd add to that, one of the things that we're known for as an association is saying health insurance is expensive because health care is expensive. It's interesting when you look at the ACA, carriers have to live on 15 cents on the dollar and provide 85 cents to go towards the cost of care. There's nothing in the ACA that holds providers accountable for being efficient. I actually am a son of two healthcare entrepreneurs, so I grew up in the healthcare business. And the reality is wildly inefficient. The business of delivering healthcare is wildly inefficient. So do you believe that we can become more efficient and that providers should be held to a standard, like insurers are held to a standard about how much they're spending on care versus how much they're spending on administration of care?
Yeah, and I think so many of these payment reforms are all about that. So if you're given a set amount of money to provide an episode of care or a set amount of money to take care of a patient for a year, you are suddenly accountable, and you're going to have to figure out. Yeah, you're going to have to figure out how to make sure to still, pay your rent every month. So I think part of what these new methods are trying to do is to have some skin in the game on the part of providers as well.
Excellent.
Next question. The ASA, the Administrative Services Agreement, often exposes many drivers of cost. Can you advise brokers how they need to interpret the ASA for their clients?
Ooh. How would I answer that question? Again, I think the lack of transparency makes it really difficult because if you can't see it, you can't measure it, and you can't improve it. So I'm not really sure how to answer that question, Bob. I hate to throw it back to you. I don't really know the answer that I would provide to my colleagues about how to address that concern.
Yeah, I don't think I'm the best equipped either, other than to say that I think that there can be a lot more expectations put into those agreements on the part of the purchaser than there are today. And we've created at Catalyst for Payment Reform some model contract language that is an example of those. So I'm not really answering the question directly, except to say that I think there is a lot more opportunity.
I do too.
One of our members says, I accept the info, but how can we as agents impact the cost curve for our clients, which will or can impact the curve globally?
So I can start a little bit and then have you tag on. I think at the end of the day, if we look at the evolution of consumer-driven health plans, they're designed to create transparency by issuing in a higher deductible, lower premium plan, to then provide some of the opportunities for a member to say, I now have a health care account of money that I'm responsible for. And if I have access to information, I can actually make more informed choices. So for me, it's engagement, it's education, and then probably what all of us would like to see is that we're all empowered. This whole notion that providers are the ones that control care really bothers me. Doctors, hospitals, and pharmaceutical companies work for us. We are the patient. We are the consumer. The whole system's been designed from the rule maker down. So I would like to see us do more work, and I think what we're talking about is going in that direction of how do we make it consumer up rather than rule maker down.
We've had great questions. I only have time for one more, unfortunately.
Okay. Thank you, Bob.
As physicians are going to reimbursements based on outcomes, what do you do about non-compliant patients? When they're fired by their doctor, where are they going to go?
You know, it's so fun to have that question with this group because my prior organization I ran called the Leapfrog Group was measuring the quality and safety of hospitals and publicly reporting on it. And I would be in front of audiences of hospital executives or doctors, and they'd always ask that question. You know, what about the patient? And I think, you know, everyone has a part here. There's no question about it. But also healthcare providers have done very, very little other than sort of transactional healthcare around trying to address what are the primary motivations of a patient. Why is it that they're not complying with a regimen? Is it realistic that they comply with a regimen that's been prescribed? And I think part of what's exciting about this newer focus on population health and integrating behavioral health more into it is that we're starting to recognize that there are a lot of complexities here that have to be addressed. So I think value-based insurance design, where people get costs waived for taking the medicines that they're supposed to or following certain wellness regimens. That's an example of where we've seen some successes. I think all the kinds of consumer incentives we've talked about today are going to help. There's no question that's part of the equation, but it's also a challenge back to the provider. What are you going to do about how you're delivering care that's going to address the patient in a realistic way, not ignoring life's realities and how they get in the way of following a regimen that's written in an ivory tower.
So with that said, please join us on March 26th for our second webinar, Transparency, Shining a Light in the Dark Corner of Healthcare Prices. Suzanne, thank you very much for your time this morning.
Thank you.
Wonderful.